sleep-wake cycle, control narcoleptic phenotype within Parkinson's, serotonergic cell loss, and noradrenergic cell loss. And in fact, this work has been taken further. This is work from Horacio Kaufman and Peter Lewitt and others with Alberto Espay suggesting that the adrenergic dysfunction in Parkinson's by itself could be a focus of treatment strategy in future. It affects not just the central adrenergic pathways, but also is implicated in the peripheral adrenergic pathway, which could also help in a diagnostic assessment. For instance, here you have a cardiac scan, MIBG cardiac scan used in our clinic at King's. Here we have the visualization of the heart in a normal subject with washout of the heart in a Parkinsonian subject. In these patients, you could argue that noradrenergic replacement or enhancement therapy might be more appropriate depending on the clinical signs. And this work, which again I alluded to earlier from Eric Walters, my co-chair, as well as Heiko Braak, who of course has revolutionized the concept of how Parkinson's develops, very elegantly charts the different non-motor symptoms on your vertical panel here versus the different stages of Braak, from the medullary, olfactory involvement right up to the cortical involvement, and how this translates into clinical symptoms. And clearly, knowledge of this is very important in relation to therapeutic interventions if we are going to go forward in future. So, for instance, at the moment in time, we'd have hardly any good treatment for hyposmia, for dysphagia, etc. So the pathophysiological basis of this is therefore very, very important indeed. The other area which is of great importance to us is the understanding the Parkinson's timeline, because our traditional treatments usually start here, and the neuroprotective treatment traditionally, but that's too late because probably Parkinson has been there for at least 10 to 20 years before that, characterized by late onset hyposmia, REM behavior disorder, and a whole other medley of non-motor symptoms, including constipation, major depression, as well as sleep disorders, other sleep disorders. So, in fact, treatment strategy for Parkinson's need to take that into account. The second thing it needs to take into account is that with the motor progression of Parkinson's, there is also an inevitable association with a large amount of non-motor symptoms. So your treatment strategy should focus not just isolated motor, increasing off period by another hour or an hour and a half, etc., but also on associated non-motor issues. And why this is so has been again shown in many, many papers since the 2006 or 5 period. Nice editorial by Pablo Martinez Martin showing that the burden of non-motor symptoms, the total number of non-motor symptoms, has a direct effect on quality of life in people with Parkinson's and also their carers, not just in advanced disease, but also in early Parkinson's disease. So this would mean the therapeutic strategies we want to define and devise in future should address non-motor symptoms, not just in advanced disease, but also in early Parkinson's disease. Measurement is very, very important, and we have good ways to measure motor symptoms. You have the UPDRS, you have the SCOPA measures, and so on. But non-motor measures have also become available since 2004. We have the non-motor scale, we have the non-motor questionnaire, we have the MDS UPDRS tool, which also has a non-motor section. And this has been nicely highlighted in this editorial published last year by Tony Shapira. And in fact, if we look into this further, this is very recent work from our group with international colleagues and collaborations, suggesting that by simply asking patients to complete the non-motor questionnaire and by taking account of how many symptoms they have marked yes out of 30 that is there in the questionnaire, you can actually grade the patients to mild, moderate, or severe burden of non-motor symptoms. And this is important because this clearly has an effect on how you're going to manage that patient. A patient who has a mild non-motor load will need a different form of management to a patient who has a severe non-motor load, for instance. And so in clinic, you can very simply combine clinical assessment of Horner-Nier stage, which is still valid after all these years, with either a non-motor scale grading, which has also been published, the non-motor questionnaire, or the MDS-UPDRS. The advantage of the middle being this is completed by the patients, it's time neutral, and also gives you a very quick snapshot view of the patient's non-motor burden and load. So those are the things that we are well aware of. Now I'm going to go into the domain that whether there might be something new in this arena. Firstly is the new clinical diagnostic criteria issued by the Movement Disorder Society. They've done 2 papers. This is the first one is Ron Postuma leading the clinical diagnostic criteria. You'll be aware that the older diagnostic criteria, the brain bank criteria, which still forms the central core of our diagnosis, excluded many non-motor symptoms as incompatible with diagnosis of Parkinson's, which we now know is not true. So one of the main things that the clinical diagnostic criteria has done has included a large number of these different non-motor symptoms within the boundary of the central motor category. For instance, having early cognitive issue is not incompatible with the diagnosis of Parkinson's. As you will see, this would belong to what we will call the cognitive phenotype. Similarly, a very interesting attempt has also been made to look at the prodromal period of Parkinson's. This is Daniela Berg leading the consortium, the same consortium, and they have assigned some likelihood ratios to some possible early risk factors for Parkinson's. This is quite a complex way of calculating the likelihood ratio with a prior, for instance. And in fact, if you look at this very busy slide, here are the likelihood ratios. In other words, if you have a symptom, what is your likelihood ratio to go on to develop Parkinson's with 80% certainty? And you can see that the overwhelming winner here is PSG-proven REM behavior disorder, which has a likelihood score or a ratio of 130, and the one that comes near that is dopaminergic PET or SPECT, showing abnormality at this stage, which has a LR ratio of 40. So it seems like in future, if you are planning neuroprotective trials, PSG-proven REM behavior disorder might emerge as one of the very important starting points for treatment addressing either neuroprotection or non-motor issues in Parkinson's disease. What about the subtyping within Parkinson's? Traditionally, we have relied on motor subtypes, tremor dominant, echinacea dominant, PIGD. We now know that these overlap. Many tremor-dominant patients end up being echinacea dominant after 5 years. Very interesting piece of work shown in the recent MDS Congress in San Diego. What we have argued for is that there are different non-motor subtypes within Parkinson's. We think there are 7 of them, and this is based on various neuropathological work and the spread and the route of spread of the process within Parkinson's. And to highlight that a little bit, this is based on a recent review that will be coming out in movement disorders. We think that the spread can occur through the brainstem and work its way up through the brainstem. Another one through the olfactory to the limbic route from Chuck Adler and Thomas Beech's group. And the third one is a direct cognitive route. This is the so-called neocortical spread as proposed by Glenda Halliday and also from Andrew Leese's group. And these 3 processes of spread, one with the brainstem dominant feature, one with the limbic dominant feature, one with the cognitive dominant feature, would involve different neurochemicals. In some cases it's cholinergic, some cases it's adrenergic, and would be resulting in different phenotypes. And knowledge of these phenotypes is therefore very important in relation to treatment. As an example, if you have the brainstem dominant, sleep dominant PD, dopamine agonist trials in that particular group might be very tricky because the patients are likely to have sleep attacks or narcoleptic attacks. So you would probably want to exclude them if you wanted to do an agonist trial. At the moment, we do not. We put everybody together, and that might be creating a lot of noise in the clinical trials category that we use. Another very interesting area in relation to this is the gut. And this is a nice review which came out a couple of weeks back from Heinz Fleischmann and co. in the Nature Reviews. And in fact, what they have again highlighted, work that we already know, that the vagus plays a central role in possibly determination of some of the pathophysiology and the development of the brainstem phenotype of Parkinson's. The vagus is intimately connected to the gut, as you can see there. And there is evidence from work and from Lund suggesting that if you put an intestinal alpha-synuclein lysate injected into the intestine, this would lead to involvement of the vagus, propagation of the toxicity via vagus to the dorsal motor nucleus of the vagus, and thereafter, within a few days, to the substantia nigra. It's nice, or it's quite tempting, therefore, to speculate that there is a gastrointestinal or an ingested route that's working through our first proposal, the brainstem limbic subtype of Parkinson's. And in fact, pathophysiology of the bowel also exists at a local level. We know that in every particular area of the gut, there is involvement, at least there is Levy body deposition. This might have functional consequences too. One of the functional consequences, and that is very relevant to treatment or intervention in Parkinson's, therefore, is the problem of the dysfunctional gut and the hurdles, which could be at the swallowing level, which could be at the stomach level, which could be at the jejunal level, which could be also at the large bowel level. These dysphagia is of particular interest because this could be a risk factor for silent aspiration pneumonia. And of course, we know pneumonia is one of the commonest causes of death in Parkinson's. So if you have a patient, even with mild to moderate dysphagia, giving these patients oral food or oral drugs, etc., could be quite tricky. And in fact, this work, which is being presented in this Congress from my group and also from various other colleagues across Europe, suggests that this is a widely underrated problem. In this multi-center study, we looked at over 200 patients who were systematically assessed for dysphagia, first by questionnaire, secondly by the water swallow test, and we found that amongst the self-reported dysphagia ones, almost doubling the rate of pneumonia, aspiration pneumonia, versus those who did not have self-reported dysphagia. And these patients were often not aware of, the physicians were not aware of the dysphagia because it's never been asked. And it so happened that they've had several admissions to the hospital and or to the GP services with aspiration pneumonia. So that's something we need to consider also in terms of therapies. It would be tempting to suggest that non-oral therapies, therefore, might be a good way to go, particularly in patients who have swallowing or delayed gastric emptying problem. And we can put all this together like this. So there is the dysphagia. The dysphagia is a risk factor, therefore, for aspiration pneumonia, and you would want to probably try non-oral therapies in this patient. In addition, we now know, and there are several papers suggesting delayed gastric emptying as a big problem, not just in advanced Parkinson's, but also in drug-naive Parkinson's disease. Delayed gastric emptying means, and this is a slide I borrowed from some of Fabrizio's work earlier, if you give these patients more and more tablets, they will accumulate in the stomach and they'll get a medication overload. Along with that, we know patients with Parkinson's have severe problems with SIBO, small intestinal bacterial overgrowth. Prevalence of that is thought to be anything up to 50 to 60%. Together, these patients would lead to several functional consequences of oral therapy, particularly levodopa therapy, which we normally assign the brain to. But the problem may well lie actually in the stomach and in the upper gut. And in fact, if you then look at the various definitions of fluctuations in response, wearing off, delayed on, dose failure, no ons, and random on and off, at least 2, delayed on and dose failures, are most likely to be related to the gut and to the delayed gastric emptying issue and intestinal absorption problems. In these patients, we have to address these motor fluctuation issues with perhaps therapies that bypass these problems. Now, is this true? What other manifestations can these have? This is a recent study, again, we published through our network of early morning off periods. These were 320 patients across various centers in Europe, where patients were asked how are they waking up in the morning and what percentage were waking up in an off state. And in fact, you see that the prevalence of EMO in this multi-center study was about 60%. So 60% of unselected Parkinson patients on treatment, obviously, had early morning off. But more importantly, 88% of these early morning off period patients had very severe non-motor symptoms. And you'll hear from Alexander Stoic in this meeting about non-motor fluctuations. These can be very disabling. Some of these patients were waking up with severe pain, some of them waking up with severe depression, anxiety, and so on, related to the off period, which is most likely related to delayed on, most likely related to a gut-related issue. And in fact, there is evidence now that early morning off particularly can be overcome with non-oral therapies. One of the first examples of this was the retigatin transdermal patch, which showed by the RECOVER study that you can get better control of early morning off. But we've also recently completed another study, it's the EuroInf study, which has just been published, also in movement disorders, where we were able to, through our network, look at apomorphine infusion patients, 43 here, with levodopa infusion patients. You can see their other demographics were reasonably matched. We looked at motor, non-motor, and quality of life measures, the 3 classical measures which we should include in any clinical trial. And in fact, what we find that in addition to motor effect, both drugs have a very good motor effect. We're looking at the effect size here. There are non-motor effects as well. And we think these non-motor beneficial effects, for instance, the levodopa infusion is slightly better for sleep, apomorphine infusion slightly better for mood. Both of these help. And both drugs help nocturia, getting up frequent bouts of urination through the night. We think this has helped because they're helping the off periods at night and getting rid of those very bad early morning off periods that were shown in the previous study. And that's not all. Just to support this, this is deep brain stimulation. This is work, again, through our network with Lars Timmerman, just published recently, showing that if you do bilateral subthalamic nuclear stimulation, and you looked at their motor and non-motor effects, you also pick up non-motor benefit, but the profile is different to what you see with apomorphine or levodopa infusion. In these patients, you have improvement principally of the sleep domain, so their early morning off improves quite significantly, and also their urinary domain improves and improves their pain, nocturnal pain. So again, you see that by providing therapy which bypasses the dysfunctional bowel route in Parkinson's disease, we are able to help by some surrogate non-motor measures. The one that seems persistent and constant are the sleep measures, particularly insomnia due to nocturnal pain or nocturnal disability, but also urinary function, pain, and in case of the infusional therapy, mood as well, not so with deep brain stimulation. What about other clinical trials? Well, this is again another recent review that we've done with Ned Schrag and my fellow Anna Saubia. And when we reviewed all the recent clinical trials for non-motor manifestations of Parkinson's disease, I initially was feeling quite depressed because usually we don't find much. But actually, since 2003, there has been quite a few trials, I have to say, both involving different pathways, psychosis, depression, sleep, orthostatic hypotension, pain, and impulse control disorders. Just very quickly to troll through these for the last part of the talk, and I'm sorry these may not project very well, but there are several trials now reporting on psychosis. Perhaps the one that is most promising is pimavanserin, which has positive effects on some of the outcome measures, but trials are there with donepezil as well as olanzapine. And similarly with depression and anxiety, mainly with depression element, there are trials with cognitive behavioral therapy which are reporting, as well as a trial that's been performed with rasagiline. Apathy is another area which is being looked at. Interestingly, unlike the other cognitive measures, apathy appears to be dopamine sensitive. So it's a dopaminergic non-motor issue as opposed to some of the other non-motor areas which seems to be more cholinergic or perhaps driven through other neuropeptide symptoms. And again, there is a trial of pyramidal in apathy from Paul Crack and co. suggesting that this might be actually a beneficial agent to use in patients with significant apathy. What about other areas? Hyperactive bladder has been looked at, and a very recent trial has been published on solifenacin, a randomized placebo-controlled trial suggesting that the bouts of incontinence and some elements of frequency are improved. Chronic constipation has also been looked at, and then pain by using subthalamic nuclear stimulation, and also by two major trials. One is the PANDA study just published, and the other one is the Dolores study, which looked at reticutin transdermal patch. Data from that will be available to us early next year. The PANDA study has just been published, and it looks at this particular phenotypic variant of Parkinson's, which is the so-called painful Parkinson's disease. These patients express severe pain, which is often unexplained. They have lots and lots of investigations. These are not responsive to dopaminergic fluctuation. It's possibly a centrally linked opiate sensitive pain, the so-called PARC pain phenotype. And in this group, if you gave an opiate drug, and this is a very recent trial published in Lancet Neurology, where oxycodone and naloxone combination appears to have a beneficial effects at week 6, 8, 4, and 12 by using a specific pain scale for Parkinson's disease and overall quality of life compared to placebo. And this remains now the first ever randomized placebo-controlled trial of addressing a specific type of pain in painful Parkinson's variant. What about other areas? Well, excessive daytime sleepiness has also been investigated by various agents. The only one that's positive so far is CPAP for patients with sleep-disordered breathing, as you will expect. Postural hypotension, again, there are conflicting data, but droxidopa, it seems to be a reasonably promising agent, as well as midodrine for orthostatic tolerance. And then one trial there is ongoing with pyridostigmine for autonomic dysregulation. Coming to the last bit, so what about dopaminergic drugs and the new ones in our horizon and non-motor issues, because that's what the focus of my lecture is. I think there are bad news when it comes to the newer drugs, as far as I can see. There's cephinamide, apomorphine, buccal formulation, the levodopas, which is the accordion pill, the skin patch, the IPX066, the inhalation, the opicapone once a day, once a day COMT inhibitor. None of these have attempted to really address non-motor issues in Parkinson's, even though there is probably, you can have a major book on the effect of non-motor symptoms and its effects on quality of life in Parkinson's. However, the good news from my perspective is some of the older drugs have all gone on that direction. Levodopa infusion has 2 major trials which will be addressing non-motor issues in Parkinson's. Apomorphine infusion has a major trial which is about to complete, Toledo study, which will have NMSS as an outcome measure. Reticutin patch has already led the way with the RECOVER and now the NEWPAT study. And the DBS consortium is also specifically trying to address the non-motor issues. So I think that's a really, really good thing, because it allows us to look at Parkinson's in a holistic manner. So you'll have motor improvement and non-motor improvement equals improvement in quality of life. So the last few points, I just want to be a bit speculative. What we really need is that our existing treatment are really only licensed for motor control. And this is in spite of the evidence that is there, that I've shown, and that many bits of it I haven't shown, which is the impact of non-motor symptoms in Parkinson's. So we really need urgent studies to investigate these, because that would only with investigation will be able to get evidence which one can put forward for specific licensing in future. And in some ways, neuroprotection remains very elusive for us, and this is something that we have proposed recently, that the new prodromal criteria that the MDS has proposed can be used perhaps in future in this manner. You have patients either with isolated non-motor symptoms, I don't know, late onset hyposmia perhaps, REM behavior disorder perhaps, or in combination, and here you apply the prodromal criteria, you then assign the likelihood ratio, and you'll get those with 80% probability of PD. You'll call them prodromal Parkinson's, and those with no 80% probability are the negative ones. Amongst the positive ones, you will have those who have the non-motor dominant subtypes that I've shown, either sleep dominant, pain dominant, cognitive dominant, apathy dominant, and those will have motor symptom dominant subtypes, which will be mainly kinesia or tremor dominant perhaps, going on to develop that, and some mixed. Amongst these, you will be able, therefore, by defining it this way, to enrich the clinical trials population. So if you are running a clinical trial, perhaps on a dopamine agonist, you'll probably want to avoid the PARC sleep phenotype, for instance. And if you can divide them up clinically, that will be really very beneficial. In fact, that's already done in cancer, it's already done in stroke, it's already done in other conditions such as multiple sclerosis. It will also allow us to look at the natural history of these subtypes in the longer term and marry that in with biomarkers and other measures, imaging markers that we may have. So I'd like to complete that and leave you with that speculative query, and I'd like to thank you and my group for all the support and help they've given us with this work. Thank you very much.